So, I think he also touched upon very widely the scope of the problem, and I would like you to focus on the red lettered line. They have very variable presentations. The treatments are very widely variable. The guidelines are very widely variable, not clear yet, and we have very few major trials. And this is one reason why, as Dr. Vijay had said, the mortality in pulmonary embolism has not improved in the last couple of decades. We really need to work on this area, and that is why another reason is that interventionalists should get involved in pulmonary embolism management. If you look at the severity of the pulmonary embolism, that is directly related to the mortality. It is related to the embolism size, it is related to the cardiopulmonary status, and what you can see that as the RV afterload increases, there is a dilatation of the RV starts failing, there is neurohumoral activation, myocardial inflammation, the enzymes get leaked into the system, there is intrapulmonary shunting, RV output comes down, LV preload comes down, coronary perfusion comes down, they all ultimately lead to cardiac arrest and death. We need to stop this cycle at the earliest, very early. And this again is another way of how a patient, telling you how the patient comes into the shock. So now first of all, why should we classify or risk stratify acute pulmonary embolism? This is because this is the one that drives the management. You need to know when to give this kind of therapy, what kind of risk classification we need to do. What are the things that we use to risk stratify? Very briefly, if you look at the history, some patient comes to us with a history of syncope, or a history of resuscitated cardiac arrest, or a sense of doom. Doctor, I felt like dying. I think I'm going to die. These are the patients we really need to take greater care. What is the heart rate? Is the saturation less than 90? Is the pressure low? How is the shock index? The laboratory parameters like troponins, the lactate levels, creatinine, the natriuretic peptides, and the imaging modalities, CT, angio, and echo. And we also have these scoring systems, multiple scoring systems we'll touch upon briefly, and the Dopplers. We have multiple ways to risk stratify. So ultimately we are all looking at assessing the health of the right ventricle. There's a right ventricle that is extremely important, and how are we going to assess the health of the right ventricle? It is by physiology. We can identify them by whether the patient has a tachypnea, is there a systemic arterial desaturation, hypoxemia, is there a tachycardia, how's the BP low? These are the physiological ways of assessing the right ventricle. Imaging, we can do the echocardiogram or a CT angio. Is there a RV to LV ratio which is more than 1? Is there RV dysfunction? Is there enlargement of pulmonary arteries? Is there a clot in transit? These are some other parameters in the imaging. They tell us about the health of the right ventricle. The risk assessment scores are there, the Hestia criteria, the PESI criteria, and the biomarkers. So, to briefly, we'll just take one case now. This was a case, patient we treated a couple of years back. 23 years old postgraduate student, shortness of breath for 15 days, and she landed up with the hemoptysis and right-sided chest pain. Post-COVID, mild COVID only. Her SATs was very low, 70 on room air and 91% 15 liters oxygen. Heart rate was 126, systemic BP was 80, and the loud P2. Now, this score is not going to help in this particular patient. This is basically the two scores that I would like you to remember in suspecting the likelihood of pulmonary embolism. There are many scores, but the commonly used scores are the Wells score and the revised Geneva score. The revised Geneva is more objective than the Wells score, and you have a 2-level risk stratification or a 3-level risk stratification. The scores can tell us that the pulmonary embolism is unlikely. We can probably investigate less. Well, we are not investigating using this score, and this is again another pulmonary embolism rule-out criteria if you can use it in the clinics. If none of these parameters are there, you can straight away say that the patient is very unlikely to have pulmonary embolism. We can comfortably probably plan a discharge with a careful waiting. But however, this is applicable only for the low-risk patients. Now, coming to this girl that we have, She has sinus tachycardia. The ECG, as you can see, that the patient has a S wave in lead 1. You don't see the T3 and Q3. But however, it's not common. It's about 50 to 60% have the S1, Q3, T3%, the ECG. By and large, every single sick patient will have a sinus tachycardia. And RV strain V1 to V3. And RV is more than 1 in V1. So these are some suggestions that the patient has a pulmonary embolism. As you can see that, this patient has a dilated right ventricle and a D-shaped ventricle. And you can also see a thrombus, 8 to 10 millimeter clot in the pulmonary artery. So this was done in a center where, you need to shift the patient for a CTPA, but then the patient is so sick and difficult to shift for a CTPA to the next block. What should we do? Now, these are some other scoring systems. The pulmonary embolism severity index. This tells us about how severe is the pulmonary embolism in this particular patient. Now this patient is 24, the patient has heart failure, that gives her 34 points, and the heart rate is more than 110, that gives her 54 points. Systemic BP is less than 100, that gives her 94 points, and saturation less than 90, it is 114 points. So it's a very high PESI score, and it is the mortality is high. In fact, I feel it is still underestimating it. The same authors, subsequently promoted a simplified PESI score by Jimenez group. What they found was they did a univariable analysis and removed some other parameters that were not significant, and they found if you take just 6 parameters and simplify the scoring system, and you find if you have more than 0, the patient has a higher risk of cardiovascular mortality in the 30 days. As you can see that the score of less than 1, that is 0, the 30-day mortality is 1.1, whereas the score of more than 1, the 30-day mortality is 8.9. And they found that the original PESI and the simplified PESI, it was equal. In fact, the area under curves was similar in this study. So we present, our data is published last month, our Madras Medical College Pulmonary Embolism Registry. As of now, this is the largest single center study in our country, 186 patients, and we had 15.6% mortality. We applied this PESI score and simplified PESI score in our population, and we found that the area under the curve was similar for both PESI and simplified PESI. So suggesting that this score is sort of validated for Indian population, we can use the simplified PESI score. So this echo PESI score is another one where they use the PA systolic pressure and TAPSE, and we found that this is again our data. It does not give any added advantage, at least in our study, it did not give an added advantage. How can we use echo for risk stratification of acute pulmonary embolism? This is picked up from the European Society of Cardiology guidelines. If you have an RV-LV ratio more than 1, or an RV systolic dysfunction, or a right to left shunt through PFO is extremely important. One of the mechanisms of desaturation in acute pulmonary embolism is right to left shunt through the PFO. And clotted transit. Why should a clot be there in right atrium? Imagine you find thrombus rolling around, swirling around in the right atrium. Why should it stay there? There is a blood flowing there, it should move forward to the pulmonary artery. The very fact that it is not moving forward to the pulmonary artery tells us that pulmonary artery is already loaded with thrombus there. So indirectly, that is how we understand that if the clot is in transit, is roaming around in right atrium, there is nowhere to go, the pulmonary artery is loaded with thrombus, and it is a high risk case. And McConnell sign, these are some other signs we can take in echo. This is another finding that you can do easily by the bedside. As you can see on the left, when you do a compression, the artery alone is seen, the vein is getting compressed here. Whereas if there is a thrombus, you find that acute femoral DVT, you are not able to do this compression, the femoral vein is still visible. This is practically done, and I think I request all the cardiology and fellows to practice this. The reason is that if you find a pulmonary embolism with the DVT and without the DVT, those with the DVT have worse 30-day mortality. So these patients, we really need to focus on managing them better. So coming to the European Society of Cardiology risk stratification, now they thankfully classified them as intermediate high and intermediate low. Based on hemodynamic instability, they classify them as high. What is hemodynamic instability? The patient comes to the cardiac arrest or a systolic BP less than 90 for more than 15 minutes with adequate filling. taken care of, or if there is a drop in systolic blood pressure more than 40 lasting for more than 15 minutes. So these are some other pointers for hemodynamic instability. On top of it, if nothing is there, the patient has a low risk of pulmonary embolism. Now with the patient, in addition, the risk factors have to be high. PESI score has to be 3 or 4, a simplified PESI score must be more than 0. In addition, if they have an imaging parameter suggesting that RV dysfunction and troponin both are elevated, it is intermediate high. If it's only one is positive, it is intermediate low. So this I think I talked to you already. So where does our case belong to? This lady, postgraduate student, she belongs to the high risk or a massive pulmonary embolism. What is the recommended therapy for high risk pulmonary embolism? Now, anticoagulation has to be started. If you suspect a pulmonary embolism, the first thing you can do is give a dose of anticoagulation. You don't lose anything by giving a patient who does not have a pulmonary embolism. So, but what has been founded, those patients who have received an unfractionated or heparin dosage or anticoagulation at the presentation, then after diagnosis, those patients, they survived much better. Systemic thrombolytic therapy is a class 1 indication, class 1 level of evidence B for high-risk pulmonary embolism, and surgical embolectomy in patients in whom thrombolysis is contraindicated or has failed. And CDT, this is 2019 percutaneous, is 2A, and ECMO is 2B in patients in whom thrombolysis has failed. So basically it says that as of now the existing guidelines state that thrombolysis is number 1. So we started thrombolysis, 2.5 units bolus, 1 lakh, and we had to give norepinephrine, and the patient required ventilation. In fact, we don't have ECMO in the system, and no CDT available. So we would not like to intubate and ventilate a patient with pulmonary embolism because it's going to increase the afterload and worsen the RV strain. So as much as possible, we tried to manage with non-invasive ventilation, but could not manage. So hemodynamically neutral ventilation is what we should do. We lost the patient on day 9. So if you look at why the guidelines recommend thrombolysis, it is based on one randomized study. If you look at the number of patients in a randomized study, it is only 8 patients. There's the only randomized study available for thrombolysis and acute pulmonary embolism as of now, massive acute pulmonary embolism. 4 patients heparin and streptokinase, 4 patients only heparin. All the 4 with heparin died and all the 4 with streptokinase lived, and that subsequently became the standard of care. And we have now data that the earlier we do lysis, the survival is better. The later, I think the slide is missing, the later we do, the survival is worse. So early thrombolysis, the efficiency is much better. Now, ECMO is another important therapy for supporting the failing right ventricle. This was a retrospective study of 32 patients, and 2/3 of them survived to decannulation, and half of them survived the index hospitalization. But this is not a standalone ECMO. ECMO along with either thrombolysis systemic in 5 patients, CDT lysis in 15 patients, and surgical embolectomy in 2 patients, aspiration thrombectomy in 4 patients. If you remember that all 5 patients who received, you see that systemic thrombolysis died. Like, when you give a thrombolysis before ECMO, they all died. But if you give ECMO first and then you give a catheter-directed thrombolytic therapy, many of them survived. So it is extremely important that ECMO has to be given a better position in the subsequent guidelines. And I'm not going into many studies of this one. And surgical embolectomy is another option that we can definitely do. This is a data from Goldberg. 136 patients with PE, of which 44 had massive pulmonary embolism. And as you can see that with the massive pulmonary embolism, they managed a mortality of just 11% with surgery. So 5 patients died and probably they were intubated. And they also suggested the patient resuscitated cardiopulmonary arrest was a predictor of mortality. So if you look at all the societal guidelines for managing high-risk pulmonary embolism as of existing today, it is all thrombolysis. All others are subsequently class 2A and V. Despite that, this is a US data, you find that the use of thrombolytic in massive pulmonary embolism is very dismally low. So many patients are not being given thrombolytic therapy, probably by the fear of thrombolysis or whatever it may be. But then in our part of the country, the thrombolytic therapy for massive pulmonary embolism is definitely higher, not as low. So now we lost that patient. We'll take another patient. Case 2, a 40 years old lady, a school teacher. She came to me with, this is almost 10, 12 years back, shortness of breath. Doctor, I'm going to die. I'm going to die. This is the complaint she said. I can't breathe. I'm going to die. Her SATS was 94. Her BP was 98/68. Does not technically fall into cardiogenic shock. There is a loud gallop. And echo showed sinus, ECG sinus tachycardia, CUS was positive, TAPC was 16 McConnell's positive, normal sized LALV, but clot seen in RPA, troponin positive. Should we do a CTPA? That is a discussion for another time. But her PESI classification is class 3, SPESI is more than or equal to 1, RV dysfunction, troponin is elevated. What risk stratification she belongs to? Now, she's a normotensive pulmonary embolism. We have a couple of scores for classifying normotensive pulmonary embolism. It started with the FAST score by the Hubham group of people, where they suggested that fatty acid binding proteins, syncope and tachycardia, FAST, FAST score they proposed. But then FABP was not freely available. The same authors subsequently, they said that if you replace FABP by cardiac troponins, the score is still valid. They made the modified FAST score. For our patient, as you can see that she had elevated troponins, she had a heart rate of more than 100, she has more than 3 points, she has an intermediate high risk group. The other score that we have is the BOVA score. This is much well validated. You can see that this classifies in intermediate low as well. Elevated troponins, RV dysfunction 4, heart rate more than 1, SBP between 90. So basically she has 7 points. She is a very high risk patient, intermediate high risk group. So now what are the challenges of these patients of the intermediate risk group? They have a significant heterogeneity. They definitely need a subclassification. And despite prompt therapeutic anticoagulation, many of them may progress to shock and death rapidly. Unfortunately, systemic fibrinolysis has not shown a benefit, as you can see that in the Payato study with tenecteplase and placebo, with a good number of patients, 1,000 patients, what you can see that it significantly reduced the hemodynamic decompensation or death in 7 days. However, there is a significant increase in extracranial bleeding and intracranial hemorrhage. So that was not helpful. This is our data from our study. As you can, we had only 83 patients with intermediate risk pulmonary embolism, of which only 20 were intermediate high, and the numbers were very low. It was not statistically significant. So this patient, we gave systemic lysis, tenecteplase, and she did well. She was on Novax for 6 months, and she continues to have a good quality of life at 12 years post-event. Now coming to fibrinolysis, somehow I feel that if I am a part of the ESC guidelines or some guidelines which classifies, I'll request the high risk classified to be very high risk PE and high risk PE. Now in the high risk PE, we know that systemic fibrinolysis works. But there is a group of patients who come to you with BP of 60, 40, arrest, resuscitation, shock. In these patients, the likelihood of thrombolysis working is going to be much, much less. In these patients, probably putting in a flow retriever or aspiration after ECMO, they are all going to help the patients more. They support the right ventricle. So here in the very high risk PE, I am not sure systemic fibrinolysis really works. Well, high risk PE, it works. In the intermediate high risk, what really happens is there is a benefit, but the benefit is offset by the harms of the procedure, the bleeding complications, intracranial and extracranial bleed, they are very low. Catheter-directed fibrinolysis and systemic low-dose fibrinolysis, anticoagulation are other options. The next speaker is not coming, Dr. Felix, my good friend, couldn't get the visa, so doctor asked me to touch some of those aspects also. So the time, I think, will be exciting. So the MOPED study talked about the reduced dose lysis in intermediate high-risk pulmonary embolism. As you can see that it is shown half-dose fibrinolysis is safe and effective. And this was not a mortality study, the numbers are not great, but however, it showed its efficiency. Then I think our previous speaker really talked about the catheter-directed thrombolysis. As you can see that this catheter helps to unwind the fibrin matrix and expose more of it to the tenective place, and the tenective place is able to work better. And this is one of the earlier approved catheters in the US by FDA. Started with Seattle 1. The Seattle 2 is a larger study with 150 patients, of which 119 patients had submassive. So we are more interested in intermediate risk pulmonary embolism. And what it showed that was there is a decreased RV dilatation, reduction in pulmonary hypertension, decreased anatomic thrombus burden, and minimized intracranial hemorrhage compared to the other group. So these are other studies of catheter-directed thrombolytic therapy. I will not go into them, but I will show you a meta-analysis. This was published last year of 44 studies, 20,000 patients with catheter-directed thrombolytic therapy for intermediate risk pulmonary embolism. As you can see in the second row, catheter-directed thrombolytic therapies versus systemic thrombolysis. The efficiency was much better in terms of death reduction, was much better with catheter-directed therapy. And it was better than anticoagulation alone, it was better than systemic thrombolysis in the second and third row. What about the bleeding complications, major bleeding? It was definitely better than systemic thrombolysis, and it was sort of equivalent to anticoagulation. So catheter-directed thrombolytic therapy probably is a way to go for intermediate high-risk pulmonary embolism. The HICC study is ongoing in higher risk pulmonary embolism, intermediate high. It is testing ultrasound-assisted CDT plus thrombolysis plus anticoagulation versus anticoagulation alone. I am sure this is going to give good data. Probably intermediate high will be catheter-directed thrombolytic therapy, low-dose thrombolytic therapy may become the class 1 indication. This I think the previous speaker alluded to. Flow retriever is for catheter-directed thrombus aspiration. You find that most of them are being done in the intermediate risk groups. This is 24 up to, there are two studies, the FLAIR study on intermediate risk pulmonary embolism. In fact, FLAIR had 140 patients, of which 35 were high-risk patients. I had excluded the high-risk, and 106 were intermediate risk pulmonary embolism, and it showed benefit. And the adverse events are only 4, including 1 major bleeding and pulmonary vascular injury, very large size. We need to be extremely careful in negotiating the catheters not to produce systemic injuries. The FLASH registry of 800 patients with intermediate and high risk, only 8% were high-risk patients. So technically, if you look at that, 720 patients with intermediate risk pulmonary embolism were enrolled, and the mortality of the total cohort was only 0.8. This is very, very good, and there is no device-related deaths. I am just showing a case, my friend shared this with, from Case Western. As you can see that this is a clot in transit, probably the PA is packed with thrombus. 71 years male, he had a fall and developed a fracture hip, and heart rate was 120, systemic saturation is 95 with 6 liters. So CTPA showed a submassive PE, clot in transit, normal LV, hemoglobin is only 7.1, lactate 3.8. So ICE was introduced through left femoral vein, and you can see the intracardiac echocardiography showing thrombus moving, and 24 French NRE on the right side. Thrombectomy was done for the right PA, and as you can see, look at that, you can see that the large catheter sucking out the thrombus. In the left side, the upper one and the lower one, thrombus is being actively sucked out, and this is the catheter having a big chunk of thrombus at the end. And this is the PA pressures to start and begin. Mean 35 came down to mean 18, and the PA saturation improved from 37 to 53, and the cardiac index improved from 2.1 to 2.8. And this patient was saved subsequently. This is the angiographic images of that. This you can see that flow retriever in action. And this is an image, as you can see, that the first image shows there is hardly any perfusion of the lower half of the right lung. And you can see the flow retriever catheter there. And this is a subsequent image which shows that it is well perfused. And this is a chunk of thrombus collected there. and if you can place it on the pulmonary artery, this was the amount of thrombus removed by the catheter saved the patient. Now this study is ongoing, CD thrombectomy versus CD lysis. Which is gooder, catheter-directed thrombectomy or catheter-directed lysis? Which is good for intermediate risk pulmonary embolism? A big study is ongoing. Hopefully, it gives some more clarity on that. I think the previous speaker nicely showed about this. I will not touch about this. So finally coming to a close, what should be the standard of care in 2024 of high-risk PE? If it's a stable high-risk PE, if the patient has a high bleeding risk, you can't lyse the patient. So catheter-based therapy should be the one, and ECMO and MCS should be considered. If the patient's bleeding risk is not very high, you can primarily go for a systemic thrombolysis. If the patient has a catastrophic or a very high risk PE, as I told you, look at if the patient is systemic thrombolysis eligible or not. So if the patient is eligible for systemic thrombolysis, look at if the patient is ECMO eligible. The patient is not ECMO eligible, go for lysis and then ongoing shock, plan medical management. However, if the patient is ECMO eligible, the better thing will be to go for ECMO cannulation, and if VA ECMO cannot be initiated within 30 minutes, do not wait, go for systemic lysis. Now catastrophic PE with the contraindication to lysis, the first thing will be if the ECMO eligible, go for ECMO. If not, catheter-based therapy for the ongoing shock. What about persistent shock after lysis? What you should be doing is that residual proximal clot burden you have to assess. If the clot burden is high, catheter-based therapy. If the clot burden is low, RV MCS. And if it is more than 12 hours, this is the outline that you can follow. So what about the low risk PE? 70% of all acute pulmonary embolism cases, hemodynamically stable, and anticoagulation therapy is the prime thing, and early discharge and outpatient management. It's very important we have to remember that the optimal duration of anticoagulation therapy, we cannot just like that be giving anticoagulation therapy. This from the READ study from the Spanish registry, it showed that the case fatality rate was higher due to bleeding than due to recurrent venous thromboembolism. And the incidence of recurrent VT was higher than the incidence of bleeding. So it is extremely important that we don't give more than what is necessary. To take home, risk stratification is very crucial because that informs us the way to manage the patient. High risk patients, systemic thrombolysis is the treatment of choice when it is not contraindicated. In very high risk patients, may need ECMO and CDT as the first line of management. Intermediate high risk patients will benefit from CDT, including reduced dose lysis or thrombectomy. And intermediate low risk patients and low risk patients need anticoagulation and close follow-up. And thank you very much for the patient listening.